Observe the mechanical stress placed on a joint during high-impact movement. Absorbing a sharp pivot or hard landing requires significant physiological resilience. In a clinical setting, we often see two opposing profiles. Patient A presents with severe joint pain, rating their experience at a 70 on a 100-point visual analog scale. Their daily function is significantly restricted. Patient B is a high-performing elite athlete, currently playing at a professional level. They are completely asymptomatic, reporting zero pain and no functional limitations. Despite their clinical differences, their MRIs are identical. Both scans show severe structural pathologies, including clear meniscal tears and the early markers of osteoarthritis. This creates a conflict with the legacy biomechanical assumption in medicine, the idea that structural tissue damage seen on a scan is the primary driver of a patient's pain. This is the title and abstract of the Scrutiny Systematic Review. Along with a longitudinal study of Australian rules football players by Dr. Don Aitken, these datasets provide a new perspective on how we interpret these images. The tension between these two cases suggests that standard imaging may no longer be a complete diagnostic tool. As we will see, in the absence of a distinct injury event, structural abnormalities often fail to dictate how a patient actually feels. To understand this gap, we have to establish a statistical baseline of joint health in active adults, starting with the data from the Aitken study. This graphic shows the top-line finding from the cohort. 90% of active athletes who are completely asymptomatic display at least one structural abnormality on their MRI. The prevalence of specific knee pathologies was high, with 67% of these players showing effusion synovitis and 43% possessing cartilage defects. The S-Scrutiny review found similar trends in the general population, reporting that up to 75% of completely asymptomatic adults have glenohumeral osteoarthritis in their shoulders. Despite these visible structural defects, these populations reported zero pain or functional decline. These findings suggest that the medical community may need to reconsider viewing these common imaging markers as anomalies or immediate indications for surgery. In active populations, these findings are often the expected morphological footprint of mechanical loading and natural aging, rather than active pathology. If structural damage doesn't inherently cause pain, why does so much clinical literature suggest a strong link between the two? This data table from the Aitken study reveals how this illusion is constructed. In the first multivariable model, adjusted only for age, weight, and height, the positive beta coefficients suggest a strong correlation between meniscal tears and a patient's pain and dysfunction. This isolated correlation is often where a clinical analysis ends. It is frequently used as the primary justification for surgical intervention. However, this model hides a major confounding variable that changes the entire result: the patient's history of injury. To identifying the actual driver of pain, we have to account for a patient's history of a specific clinical injury event. Returning to the same table, look at the second multivariable column, which is further adjusted for the history of knee injury. Once this injury history is factored in, the significant association between the meniscal tear and the patient's symptoms disappears. This introduces statistical mediation, a single acute injury event that causes two separate outcomes: the patient's pain and the abnormality on the scan. The MRI finding is merely a physical footprint, not necessarily the active source of pain. Other data supports this. A history of surgery is a strong predictor of finding cartilage defects on a scan. The MRI is a document of the past. This suggests injury history activates the clinical significance of a structural finding. Without that history, the scan may be showing us something benign. If chronic abnormalities are often asymptomatic, what happens when a player suffers a genuine acute injury during the season? The clinical reality of an acute injury is immediate. On average, pain scores spike by nearly 30 points. These scans provide a longitudinal view before and after an incident injury. Image A is the early season baseline. Image B follows a reported injury. The red arrow indicates a newly developed tibial bone marrow lesion, not present at the start of the season. The study found that acute trauma carries a 2.9 times higher relative risk of developing these new or enlarging lesions. This defines the distinction. An acute injury triggers a specific physiological response to trauma, distinct from the chronic adaptations we see in asymptomatic joints. These findings suggest a strong need for clinicians to adjust how they triage patients based on medical imaging. We can model this as a clinical decision tree. If a patient presents with a torn labrum or meniscus, but has no history of a congruent acute injury, then intervention specifically targeting that abnormality is unlikely to be warranted. However, if the structural abnormality is paired with a distinct recent mechanism of injury that matches the image, then targeted intervention is justified, as the pathology likely represents an active clinical state. High-resolution imaging is an essential tool, but it must be viewed as secondary to the patient's clinical history and the physical examination. The goal is to treat the patient, not the scan. We must avoid confusing benign structural footprints with the active causes of pain.